Welcome everyone to the Joint Conference Committee for excuse me, Laguna Honda Hospital for September 12th, 2023. Can you please call the roll?
Sure, I'll start with you, Commissioner Guillermo. Sorry.
Present.
Commissioner Chow.
Present.
Commissioner Green.
Present.
And I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the August 8th, 2023 minutes. Please turn on your microphone, Commissioner.
Thank you. Okay, have the minutes before you. Let's see if there is a motion to approve.
So moved.
Okay, is there public comment?
Yes, I see one hand. And folks on the line, I'll just say this repeatedly, but we start with those who received accommodation. I've given accommodation to 2 people. If you are one of those people, please keep your hand raised. Everyone gets 3 minutes for each of their comments. Hey, caller, you're unmuted. Please let us know that you're there.
I am. It's Patrick Monette Shaw, code AA.
Please begin.
It's disturbing reading in these minutes that Commissioner Lori Green, MD, noted that, quote, some populations have been excluded from the current draft of Laguna Honda's admission policy, such as those whose primary diagnosis is a psychiatric-related issue, unquote. As far back as 1999, Laguna Honda's admission policy has always excluded patients having primary psychiatric-related medical and behavioral health diagnoses. It's almost as if Green has no clue of Laguna Honda's past 24-year history. That exclusion is for good reasons. First, Laguna Honda is not a licensed psychiatric facility. Second, Laguna Honda does not have and never has had a full contingent of psychiatric clinical staff, and even now is having difficulty recruiting psych social workers, psych MDs, and other psych clinical staff. Third, Laguna Honda doesn't provide the scope of services to adequately care for people with primary psych diagnoses, and they should not receive an inappropriate level of care at Laguna Honda. They deserve better than being wrongly dumped into Laguna Honda, where they won't receive the level of care they deserve. Thank you.
All right, thank you. That's the only hand that I see. I want to call it again. We're on item 2, the minutes of the last JCC meeting. Anyone else? All right, I don't see any other hands, commissioners.
Thank you. Are there any comments or corrections, changes to the minutes? Okay. I have a motion and a second. All those in favor?
Aye.
Aye.
All right, thank you. Item 3 is general public comment, and this is a time when folks can comment on something that's not on the agenda. Again, we'll start with those folks who've received accommodation from me. Please press *3 if you'd like to make comment, general public comment. I see one hand. Caller, please let us know that you're there.
Oh, no, I did not raise my hand for public comment, Mark.
Okay, thank you, Mr. Minetcho. All right, anyone else? General public comment. All right, there's no hands and there's no one in the room, Commissioner. So we can move on to item 4, which is the executive team report, which I will pull up.
Mr. Pickens?
Yes, so Mr. Pickens, the microphone will pick you up. Just talk.
Perfect, thank you.
Yes.
Good afternoon, Commissioners. Roland Pickens, Network Director. And I'm joined here today with Laguna Honda Nursing Home Administrator and Chief Executive Officer Sandra Simon. And we are being supported virtually by members of the Laguna Honda executive staff who will also participate in the presentation and also be available to answer any questions that you might have. Next slide. So as you are aware, we are still on our path towards full CMS recertification. You are aware that we have been recertified in the Medicaid program that happened in early August. That was a great milestone for us since 95% of our residents are supported by Medicaid. And that recertification was a direct result of all of the work that's been done over the last 16 to 18 months to improve the quality of care and oversight of operations at Laguna Honda. Next slide. Continuing on our recertification journey, having successfully been recertified in the Medicaid program, on August 23rd, we submitted our application for Medicare certification. And we were able to do that because of the great progress that we've made that resulted in the Medicaid certification that gave us a boast of confidence that we will be successful when we actually sit for that Medicare survey. Consequently, as a result of submission of that application, we are now in the survey window and are expecting that CMS survey team to arrive at any day, any time, and without notice to begin that survey. As we did with the Medicaid survey, our goal is to demonstrate to CMS that we meet their high standards of resident care and safety, and we should therefore be allowed re-entry into the Medicare program. Next slide. Throughout this whole process, we remain dedicated to making sure that the residents at Laguna Honda and those in the community who need Laguna Honda services will be able to have it for the next 150 years. We remain committed to making sure that we continue in our process improvement, regulatory oversight, and safety measures to ensure that Laguna remains in good standing with all federal and state programs. Next slide. As you know, the action plan that resulted from the root cause analysis has been our guide towards recertification over the last 12 months. We have submitted all of the required action plans, milestones that came out of the last survey. That included 300 additional milestones that were submitted on top of the 500 that we had already completed through May. We are on track for submitting those milestones. In consultation with the CMS quality improvement expert, in order to make sure that staff would be as prepared as possible for the forthcoming Medicare survey, the QIE has allowed us to have a pause in our milestones for the next 30 days so that staff can exclusively focus on survey readiness. The milestones will be picked back up at the earliest of either completion of the survey or the end of that 30-day period. Those milestones are important because they represent plans of correction that we submitted for all of the previous surveys over the last several months. And so therefore the milestones must be completed. Next slide. So in our last survey, we took the opportunity to include our second annual Laguna Honda-wide staff training. We had over 1,000 staff, including myself and Ms. Simon, who went through the training. It was a week long and covered many of the issues that have been identified in the most recent surveys in terms of fire life safety, grievance process, um, and reports of abuse and such. We've, as I mentioned before, it's been determined that this really adult learning technique of face-to-face didactic education seems to really work well with the staff at Laguna. Historically, Laguna has depended upon an electronic monitoring platform where staff would just log into a computer, take a test, and pass. While some of that still exists, it's greatly being replaced by face-to-face didactic training. And we find that it appears to be more successful in terms of staff ability to retain the knowledge and to be able to explain processes to surveyors. Next slide. This is our usual chart that shows admissions, discharges, and expirations. As you know, we've been on hold for admissions, which I'll talk about in a few minutes. And as usual, we usually have anywhere from 2 to 3 or 4 expirations per month. And you see this reflected in the data here. Next slide. So before I end, I mentioned admissions. Obviously, with the successful Medicaid certification, members of the staff and our residents and the public are wondering, when are we going to resume admissions at Laguna? And the answer to that question is when we're ready and prepared to increase our numbers. While it's great that we pass our Medicaid survey, we still have yet to pass our Medicare survey. So it's important that we keep the focus on getting back into regulatory compliance. So that's one of the milestones we'll need to meet before resuming admissions. The other milestone is, while we've done great work in terms of improving processes and gaining regulatory compliance, there are still gaps in our process. You recall that we implemented the Consistent Care at the Bedside Initiative, the CCBM, where we brought in a director of nursing level individuals and placed them within each of our 13 units. That process actually kicked off in June, so we've got about 2 months of the experience under our belt, and it's proven to have been very effective because now we are actually finding gaps in care real time on a daily basis across all shifts, and those gaps are then covered on a daily basis through a process that our nursing home administrator leads called the IDT, Interdisciplinary Team, where all the staff, the leadership from across the hospital assemble in her office every morning and review any identified gaps in care or regulatory compliance. As such, we know despite our great progress, we still have significant gaps that would make it imprudent to begin readmissions at this time. In addition, we continue to have, like every healthcare provider, vacancies in some of our key positions, particularly food service, activity therapy. So in good conscience, we cannot bring in additional residents if we don't have sufficient staff to provide those services. So those are some of the milestones that we're looking at needing to be met before resuming readmissions. We recognize the importance of Laguna Honda in San Francisco being the largest facility, the facility that takes predominantly Medicaid sources that many of the other freestanding facilities don't take. So we take our responsibility for being open for admissions very seriously and are committed to doing so as soon as it's feasible. In addition, there have been questions about the 120 beds, the triplets that we've all learned about over the last year. When we received Medicaid certification, that was based upon our ability to meet the current federal regulations, which exclude those 120 beds. You'll recall that we kept those beds on our hospital license because we still plan to resume the process to get those beds relicensed. In our conversations with CMS, they've made it very clear that they understand that we want those 120 beds back, but they also want us to first be back in full regulatory compliance, and that means Medicare certification. In order to get those 120 beds back into operation, it requires us to submit a waiver request to CMS. And again, CMS has made it very clear that they would not look favorably upon that waiver request until we are back in regulatory compliance. So similar to our admission status, we know how important those 120 beds are. We are bound and determined to get them back. And even when we took them out of use, we did it in a way that would make it quick and easy to put them back into use once we have the appropriate regulatory approvals. And so those are our plans in terms of admissions and the 120 beds, and look forward to having more dialogue with the JCC and Full Health Commission. And at the appropriate time, happy to answer any questions or hear comments that you'll have for us.
Okay, thank you, Mr. Pickens, for your report. See if there's any public comment.
Yes, give me a second, please, to pull something up. Okay, callers, we're on, for people on the line, we're on item 4. If you'd like to make comment on the executive team report, please press *3. I see one hand. Caller, I've unmuted you.
Oh, I'm sorry. Can you hear me?
Oh, yes.
Oh,
I'm sorry. Did you want to make a comment?
briefly, yeah. I'm encouraged by the report. It would be nice if there was any kind of sense of time frames in terms of readmission and opening up the waiting list. It's really good to hear the dedication to holding on to those beds. They're very, very much needed. The community beds, as you know, have diminished incredibly. So I'm with the Gray Panthers. As you know, we've been watching this very carefully, and fingers crossed, it's going in absolutely the right direction. Thank you.
Thank you. All right. You're unmuted. Please let us know that you're there.
Oh, hi, this is Dr. Palmer, WW. Can you hear me?
Yes, please begin.
Yeah, it's a little disturbing that the staff at Laguna Honda is so profoundly untrained, and I can't help wondering if the skill mix is contributing to that. Where you have, instead of CNAs, you have home health aides and patient care assistants. If the staff simply doesn't know what to do, and it's so difficult to train them what to do, either the patients you're admitting are too complex, and that comes to mind the acutely behaviorally unstable patient, or the staff skill mix is not good enough. I'm wondering if that is being looked at, because this is now taking forever to resume admission. And people are suffering, having to go out of county, having to stay in hospitals. This is really a dangerous situation. And one of the things to do is to make changes so this will never have to be repeated. You don't want to take a chance on being decertified again. When might Medicare certification be obtained? Could we have some ballpark idea? And why is there no priority to return evicted patients, the ones who have survived and want to come back, or any patient that's been kicked out of county because there's no beds at Honda? It's really important to prioritize these people. People in San Francisco have a right to grow old in their own community, and there's no indication that this is any kind of priority at all. Thank you.
Okay, looks like we have one more hand. Caller, you're unmuted.
Oh, that's me. No.
Oh, sorry.
For me? There we
Yes.
go, Mark.
Okay.
Can you hear me now?
Yes.
It's Patrick again. I'm submitting today results of 1,600 signatures initially collected during a Change.org online petition drive addressed to Board of Soups President Aaron Peskin and Health Commission President Daniel Bernal. The signatures collected include 410 or 25% from San Franciscans and our neighbors in the Greater Bay Area. 570 or 35% came from across all California jurisdictions, demonstrating broad community support to permanently save Laguna Honda's desperately needed 120 beds. The remaining signatures came from allies across the U.S. and foreign countries. The document I'm submitting includes compelling online comments posted on change.org. Please display my overhead slide. I also submitted these signatures to the Board of Suits at 3 o'clock today. The petition remains open on change.org for those who may still want to sign it. Laguna Honda's CEO told the Board of Supervisors on May 9th there's a waiver process and CMS and CDPH are open to the waiver. Pickens is confident Laguna Honda meets the waiver requirements, and I think he's wrong. I think 42 CFR states that waiver application is submitted to the state agency, not to CMS. There's no reason to believe CDPH would approve Laguna Honda's Medi-Cal certification, but not approve the 120-bed waiver request. It's a decision of Tomas Aragon, director of CDPH, not CMS. Commissioner Bernal and this JCC should direct Laguna Honda to immediately submit its waiver request directly to CDPH Director Tomas Aragon. It's time you take this overdue action now. Thank you. And stay tuned, Mr. Morwitz, for the document I'm sending you now.
Okay, that is the last public comment request for this item.
Okay, thank you for your comments. Are there any from the committee? Questions? Yes, Commissioner Green.
Yeah, thank you for this update. I wonder if you can elaborate a little more on how the milestones interface with the elements surveyors might be checking on when they come. And then the other thing you mentioned in the report is the whole issue of staffing. Can you elaborate a little more on that as well? Because I know at least we have not diminished the numbers of staff despite the significant diminishment in the number of residents. So in our core areas like nursing, can you elaborate a little more on where we stand? And also perhaps on the processes of expeditiously hiring people for things like food service.
Sure. Thank you. The first question, the milestones in terms of how that might relate to the surveyors. So whenever surveyors come in, they look at the most recent data for a facility. And that data represents both anonymous self-reports or the facility reported incidents, and also the most recent surveys that they've done. So they collate all that information and they look for trends. So the fact that we had milestones developed based upon findings means that when that survey team comes in, they have the most recent surveys. They know where the most recent findings were. And those are the areas that they're going to focus on first. They will still look at the entirety of all the CMS regulations, but they first start on what are the known vulnerabilities or areas of gap. And so they will use those milestones as a guide to their survey process when they come on board.
So how does suspending it relate to them? And then do you anticipate that CMS surveyors would look at this through a different lens compared to the CDPH?
Suspending, we don't feel will have a negative effect because again, the gaps that they found were ones we were already aware of and were already in process of fixing, just had not completed that process at the time of the survey. So they were not new areas, with the exception of that one, remember, the home-like environment, where now we have tablecloths, real china, those kind of things. That was the only area of a new issue, but the ongoing issues were the ones we knew about. Restraint, individualized care plans. So all those improvement processes that were put in place going back 12 months, but also the more recent efforts based upon the last survey are still happening. We're just not actively reporting on them in the milestone calendar. We're basically pushing the calendar back 30 days because, again, staff have a finite amount of time and energy and effort. So we made the choice. What was most important at this point? And that is getting that Medicare certification. So we wanted staff to be able to focus their efforts on survey prep while still doing the improvement work, but not necessarily having to meet documentation deadlines of, X number of audits done and submitted on X date. We need to give staff a little bit of a respite from that because it was beginning to be a bit overwhelming. In terms of staffing, so as you know, staffing is a barrier for just about every healthcare organization. And you are correct, we did not reduce any staffing at Laguna since we started the recertification process, but yet we have about 200 less residents than we did when we started. Having said that, there are still vacancies in our staff. I believe the last report, there's a report coming today. I think the vacancies for RNs was about 11%. It's been vacillating around 12, between 10 and 12%. Activity therapist, I believe the last report I saw showed that there are 10 vacancies. And that's a critical position because the activity therapists are the individuals that, as you can imagine, who help make sure that residents are stimulated, have activities to keep them engaged. And so while we have those fewer number of residents, we're able to accommodate that because we have enough activity therapists for the roughly 500 residents we have now. To begin to add more residents without that staff, I think puts us in a very dangerous position because then we wouldn't be able to provide all the required services on a timely, quality basis. And so we've got to balance all these things, making sure that both we have the gaps in care and compliance taken care of, but also that we have sufficient staffing in place to accommodate new residents coming into the facility.
Thank you. And is recruitment ongoing it seems from the report that I think we're going to have shortly, that's definitely going on.
It is. There have been a couple of big recruitment fairs just for Laguna Honda. We have a new director of HR operations at Laguna Honda, Priya. She started a couple of months ago and is doing an excellent job. Laguna is working closely with Zuckerberg Zuckerberg sends over the occupational health physicians so we can actually do the physical exams on site in order to cut down on time as opposed to scheduling and having them go over to Zuckerberg for physical. So there's a lot of collaboration being done on the hiring side, and we're hoping to see that pay off. But at the same time, it is a challenge in this competitive environment to fill patient care assistant positions because everybody's competing for the same talent.
Well, thank you. And I think it would be helpful going forward to hear a little bit about how process is proceeding, and also to understand your thinking about if you got 5 activity coordinators, how many new residents could you admit? I mean, you're probably going about some very thoughtful processes in making that determination, but I know everyone's eager to see admissions resume, and if you can keep us in the loop, it'd be great.
Absolutely.
Any other questions? Yes, Dr. Chow.
Yes, thank you. And I had several questions from your presentation, and thank you again for the clarity of the recertification by Medi-Cal versus the to be recertified Medicare process. Within that, trying to be sure that I'm understanding, because I've not actually heard it from you, that the September 19th pause has been truly paused for transfers.
Mhm. So we've not received anything officially in writing. However, we've had no indication that anyone is expecting us to resume transfers on the 19th, nor are we making any preparations. So from our perspective, that date has no significance. We are continuing on business as usual, taking care of all the residents that we currently have, and have no intention to begin any kind of transfers.
So that was a conversation with CDPH or with CMS?
So there was no conversation. By virtue of the Medicaid certification, we believe that establishes the position that we are not required to move forward with transfers on September 19th. And we've not had any indication that CDPH or CMS have an issue with that position. So
Okay.
yeah, so.
Okay. No, that's fine. That's important to try to understand which way we are understanding, because I would agree with that, but I'm not CMS or CDPH.
Right, yeah.
So
And I acknowledge it is confusing because for a while we were really focusing on that September 19th date, thinking that we had to have the Medicare survey before then. If not, we would have to resume. But we've since reevaluated and looked and believe that the Medicaid certification uh, then made that September 19th date no longer a valid date for transfers.
okay. So have you clarified that for Medicaid patients who were sent away during the last transfer, that they could or could not be readmitted, or your feeling is that you don't want to really open that question?
Well, it's clear. So we have made it clear that anyone who was transferred out of Laguna under that previous process is the first priority for readmission when we do open for admissions. Having said that, um, the admission process, um, recognizing that while 95% of our residents have Medicaid, many and most of the time when they first arrive at Laguna, they actually come with Medicare. Medicare offers a limited number of days per year, and they usually then transition from Medicare to Medicaid while they're at Laguna. So that's why it's important before we resume admissions that we need to get that Medicare certification, because if we don't have it, many residents won't meet the admission criteria because they won't have then that Medicare. We won't be an approved provider in the Medicare program to which to receive them. But in terms of those individuals coming back, and as you know, the changes we're making in our admission policy, I think are spelling out that those individuals do get first priority upon when admissions do resume. That those who still meet skilled nursing criteria and who want to come back have the first priority.
Okay, so you're actually waiting for Medicare in order to even bring that back to be sure that they qualify for skilled nursing before they then end up on back into the long term.
That's true. And remember, you know, we have oftentimes residents, if they get sick or an infection, will have to be transferred out to acute. Well, if they're Medi have Medicare and Medicaid, when they come back, Medicare kicks back in. So again, we won't be able to take them back if we're not certified in the Medicare program when they get sent out for a few days or a few weeks to acute and then need to come back to Laguna Honda.
Right.
So it's all connected.
Okay,
Excuse me, Commissioner Chow, I apologize for interrupting. I just want to note this, that the commission approved the Laguna Honda admissions policy at the last full commission meeting, and I'm just going to state what the first priority is. Residents who were involuntarily transferred and meet the criteria for care at Laguna Honda Hospital will be considered new admissions and given first priority when we begin to evaluate new admission requests based on Laguna Honda's admission criteria. Just want to put it in the record that that's been codified already.
right. No, thank you, Mark. I'm well aware of that, and I'm glad you've restated it for clarity of the public, because it sounds like part of the public doesn't really understand that we've already placed that in. And our question here was, okay, when does that come into effect? And it sounds very reasonable that because Medicare can certainly be involved because of all the rules that in order just to be sure that these people can be admitted, then we are awaiting the Medicare certification before we start implementing admissions.
Absolutely.
Okay, that's, the other one, which I found interesting, was your discussion of electronic learning versus face-to-face. And I'm wondering if that's really versus, or as I understand it, if we're not using ELM as a tool, or did you really mean that this is now going to be hybrid education and there would be both processes being used, but that the new addition is really a face-to-face that, and probably one that would reemphasize what they may have seen in a ELM or large presentation. Is that closer to where you were going? Because I thought that you were giving the impression that we were abandoning ELM.
Yeah, thank you for clarifying. And no, we are not abandoning ELM. We are going to that hybrid model. Still, some courses are through ELM, but then others are the face-to-face didactic. And particularly for nursing personnel, they always had a number of face-to-face didactic, but it's the non-nursing personnel who we are now using the face-to-face with. And they were almost exclusively all electronic platform, but now, and because we found that was one of the gaps in staff knowledge, that ELM process was not adequate for the non-nursing staff. And so we're doing face-to-face, more face-to-face training for them. They are now getting that face-to-face that the nursing staff always got.
Good. I think that's helpful in understanding some of the root causes for people who look like they were ready in your scoreboards, but that was through just electronic presentations rather than that need for also a face-to-face intervention in certain types of skills that are really best learned both ways. So that's very helpful. I think you also mentioned, and this was along that same idea, that the CCBM program was continuing. And I think in the past you said it might continue to the end of the year. And so have you found that that also was helping to fill some of the gaps? Because it's kind of nice to know this was a large expenditure, which, as you say, you were proud to take ownership of. And I was wondering if you really feel, or maybe I really welcome the assignment. Maybe she would like to tell us what she's found in terms of it being helpful.
Yes. So yes, it is very much still helpful, very much still needed, definitely through the end of the calendar year. And we will reassess, and if needed, we are prepared to extend it even further. Again, we want to make sure that we are setting up Laguna for long-term success. We don't want to pull back too much too fast. So we want to give ourselves the longest runway for continued improvement in regulatory compliance. And I'm happy to have Ms. Simon share her experience, particularly with the CCBM and some of the other new initiatives she's brought to Laguna.
That'd be very nice. Thank you.
Good afternoon. In regards to the CCBM program, I'm finding it extremely helpful as they are coaches and partners to the nursing leadership on each unit. And so not only are they there to do rounds and coaching, but they're able to coach the unit managers in practices that are standard in other skilled nursing facilities and homes that I've brought in. For example, an interdisciplinary care process where we are reviewing the last 24 hours as a team. And so they are able to be there, helping them doing the reviews that are needed, coaching them what to look for, what to escalate up, and how to bring the team together on their units to update plans of care and other processes, put interventions in place, and then also come to the, what I call, I'll back up and explain to you what I'm talking about. But so the CCBMs are very helpful in not only in the rounding, but the coaching and the mentoring of the unit managers at the unit level and what their roles will be to continue and to sustain for our sustainability plan and program.
So just as a follow-up, did you think that the staff has not only accepted but embraced the idea that here were people that could also be helpful?
I'm sorry, say that again.
That the CCBM well, I don't know if you call them coaches or, but that they're being accepted by the staff and that there's a collaboration here rather than something imposed from the top down, right?
I think, yeah, for the most part, I think in the beginning it was maybe I got there maybe right after it started. There might have been a learning curve or people weren't sure what to expect, but it's become, we're really working to have it be collaborative and coaching for the unit managers, but also being a second set of eyes and being the consistent rounders for at all times of day. And I can tell you, we've gone in on the weekend, in the evening, on a Sunday night, going in and rounding, and it has worked because you'll see people, the masks are on, everything's in order, med carts are locked, everything, the processes that we've been trying to prepare for is becoming ingrained and part of the culture and the culture change. So it's not only when people are looking, I guess is what I'm trying to say, it's always. And I attribute that to the work of the team, but also the CCBMs, their coaching and rounding.
Very
So
good.
it's been very helpful with the culture change.
Oh, okay, because it is a rather expensive item. So, okay.
Yeah, and
Well-
then just the initiative that the process that I've brought to Laguna Honda is an interdisciplinary stand-up process, and it's 3 phases. And phase 1 happens at the unit level, where all of the interdisciplinary team comes together with the nurse leader, and they're reviewing key indicators for the last 24 hours, and it's dietary, rehab, nursing activities, social services, reviewing, there's a set agenda of items they need to review, report on, update plans of care, verify medications, just having a cohesive and integrated approach to care. From there, there are items that come to phase 2 in my office, where each unit manager comes, and there's also the department heads there, and we're there to not only listen to what is happening on their unit, but to remove any barriers that they may have in resident care. At that point, it's a report up. If there's anything that needs a problem solving, there's a sidebar happening in my office. From that, there's phase 3, which I report up any other escalations to Roland and the executive team. If anything in the morning doesn't have a resolution that meets the expectations, and there's something called a stand down, where they come at 4 o'clock and report back any deliverables that needed to happen for a higher escalation. So we rolled it out 3 units at a time, and we're on our 5th week. And I feel, I don't know, Roland can speak to it. It's really been helpful in integrating the team and breaking down silos and having a good communication. We're also reviewing the CCBM rounds at that point, so we can give folks education for that day if needed, or coaching or accountability, anything that's happening. But we're reviewing things in a 24-hour time period, but on Mondays, of course, it's the weekend, so a little bit longer of a meeting.
No, thank you very much.
Yeah.
Appreciate the description of this initiative that you've initiated. Right. But it speaks to, I think, the need for cultural change uh, at Laguna Honda, in addition to really sort of making sure that the sustainability and the stabilization of all of the changes that are being made aren't looked at as just a top-down um, process, or that there is the sense of more collaboration and interdisciplinary problem solving and execution around all of the new policies and procedures. So appreciate that description. Looking forward to hearing more about it.
It's
in
a
the
key
future.
to sustainability and the communication and bringing that staff. It's not, like you said, it's not executive led. It's everyone's has a role and key players in this process, and ultimately giving the best care to our residents bedside.
Great. I just have a couple more questions then for either of you, probably more at this point for Mr. Pickens. With the survey that's we're anticipating any day, we're hoping that to have had it done already, but in any case, do you know, is it going to be a CMS team, or are they going to delegate that to a CDPH team? And will that have any effect on the timing of the survey?
Yeah, great question. So I asked the CMS and CDPH leadership that question. They would not give a definitive answer other than saying that that the CDPH team would be coordinating the survey team. So, you know, we've had a mixed bag. The first survey was a mixture of CDPH and CMS surveyors. The second survey was was CMS surveyors only. But based upon the feedback they got, I'm anticipating it's going to be a CDPH survey team. But again, they maintain discretion to send out whomever they choose.
Okay. And we won't know in advance at all. We'll just know when they show up.
Correct.
Okay. The last question I had, and thanks to my fellow commissioners for asking other questions that I had on my list, but there was one that they didn't ask, around the admissions, and this isn't the admissions of residents that were previously at Laguna Honda that were transferred out, but those, when we start new admissions, generally, have we, or are there preparations for whatever steps in the process that we'll need to take sort of in place, or, you know, just anticipated so that people can be prepared when we do get recertified by Medicare, so that we can quickly start the readmit process or the admit process as soon as possible and efficiently?
Right. Well, it won't be a difficult process. We'll basically turn back on the admissions committee. So that committee consists of physicians and nurses. And so they're the ones who review each referral packet. And so they'll now need to do it based upon the most current admissions policy that gives first preference, again, to those individuals and any other changes that we made, so that that the criteria that they're using closely then follows that admissions process. So it's basically a matter of just getting the committee back up and running on a regular basis. Typically, they would meet a few times a week to review referral packets that come in. So it's not an arduous process. It's just telling them that they're back in business and they've been on hiatus during this whole time.
Given that there have been changes in key personnel since the decertification, this admissions team, are there significant personnel changes on that team where they might have to get trained or educated on the process, or have to get familiar with what that process is going to be?
And you are correct that there have been many of the individuals who are on that team have either retired or moved on. So there is a new group. So there will be a orientation training process for the committee itself that we will need to build back into some lead time in order to make sure that they are appropriately trained and equipped to do that function in accordance with the policies that have been approved.
Because I would imagine that's an important
Yes.
piece to it, particularly given that we've made some changes in the policies around admissions, as well as folks sort of being able to come together as a team in order to be able to sort of be on the same page as the process is progressing.
Absolutely.
And again, needing to be done as quickly as possible.
Yes, we'll have our Chief Medical Officer, Nita Ratanawaksa, and our new Chief of Medical Staff, Dr. Emily Kanabuchi, help lead that process of reestablishing and getting the admissions committee trained up accordingly so that they'll be ready when we do make that decision to resume admissions.
Great. Okay. Well, I know we're all looking forward to seeing that happen. So glad that you're ready for that. I think that's all the questions for now. We can move on.
All right, thank you. Item 5 is the hiring and vacancy report.
Is that Priya?
Yes, Priya, I see your name. There we go. Hi.
Good afternoon, Commissioners. Priya Nayar from HR reporting out for Laguna Honda. Total hospital vacancies decreased in September to 10.9% from 11.9% in August. We have hired a total of 24 employees between August 1st and August 31st of last month in various classifications, and we had 13 separations during the last month with no retirements being processed. Nursing hiring highlights are in vacancy. We continue to prioritize and support with the hiring of the RN class. The vacancy rate currently stands at 11% for the month of August, which relates to 24.5 open vacancies. Of these positions, we are currently onboarding 8 candidates with appointment dates planned for the 16th of September. Hiring managers are currently involved in the selection process for the remaining 16.5 positions. Especially of interest is that HR is also leading efforts with batch hiring process of certain job classes where we see continuous demand for talent. By focusing the efforts on batch hiring, we aim to make hiring process more efficient by consistently having identified pool of skilled candidates to engage with, consolidating the selection process across the various divisions, and it also helps with onboarding candidates much faster. Special mention, just because there's been a conversation before kind of my update on, hiring and the demand for talent. Special mention is the 44 2303s or the patient care assistants that we are currently onboarding with appointment dates all planned for this month. Specifically calling out RN highlights for this month, we have 8 2320s and 6 P103s targeted to start in September. Non-RN hiring highlights include 1 2471 radiologic tech appointed in August, 1 2472 radiologic tech supervisor appointed in August, 3 P103s appointed last month at Laguna, and 3 2303s patient care assistants started last month. Thank you.
Excuse me. Thank you for your report. Is there any public comment?
Folks, we are on item 5, the hiring and vacancy report. Please press *3 if you would like to make comment. I see one hand.
Hey, Mark, it's Patrick. Can you hear me?
Yes, please begin.
Thank you. Recent hiring and vacancy reports have not provided any updates on the status of hiring Laguna Honda's medical director. According to public records I've received, Laguna Honda has paid 2 invoices to Berkeley Search Consultants, one for the, quote, due on completion of recruitment brochure and job posting, end quote, phase, and one for the, quote, due on closing date and presentation of candidate slate presented, end quote, phase. at $23,000 each for a combined total of $46,035 for recruiting a medical director. The invoices provided don't include the third or fourth phases of submittal of the recommendation of most qualified candidate and the actual due on acceptance of job offer. There was some sort of hiccup over whether applicants could have outside employment or outside volunteer work, which is provided for in the city's employment rules. Since CMS and CDPH were quite concerned about Laguna Honda hiring and onboarding a qualified medical director, what's the status of recruiting for this critical position? Surely there are viable candidates. As for Mr. Penn's claim you're having trouble recruiting food service vacancy replacement and activity therapy, the vacancy report shows that you only have 6.5 vacant food service and senior food service workers. And because the activity therapist job classification is not known, why aren't you using registry staff to fill both the food service vacancies and the activity therapy vacancies so that you can resume admissions? This is really disappointing hearing this. Thank you.
That is the only public comment on this item.
Thank you. Are there any questions or comments from the commissioners? Okay, Commissioner Green.
Thank you for the report. I just had one question. I wonder if you can tell us a little more about the nurse manager hiring, because although it's 5 people, it is 19%. And since it's such an underpinning of being able to sustain all the progress that's been made, and eventually the advisory nurses that we have at the bedside as part of the initiative will be leaving. So I'm wondering what particular skill sets required. To what extent can you hire from within? Because it's one thing to hire a bedside nurse. It's another thing to hire someone with nursing home experience who can also act as a leader, especially if they haven't had the benefit of working with the team that's been here helping the people that are now on the ground. So I'm wondering if there's a timetable or any information you can share on that particular vacancy portion of the report.
I can definitely come back to you with all the information you've requested.
Great, thank you.
Thank you.
Commissioner Chow.
Yeah, I just had one question, which was that I realized that the report does not include, I guess, hiring for these administrative roles such as the medical director, or is it under some sort of other categorization that I am missing?
No, the chief medical officer, should be 1165.
I see it at page 104.
104. Oh, okay. Okay. 765. Yeah. We'll have to get back to see if that's it, but I can give you an update on that chief medical officer. So there are candidates that have been interviewed and are in the selection process as we speak, and that selection process does include an appropriate vetting of any outside employment opportunities. And so that is where we are with the current pool of candidates that have been interviewed. And we're going through that process with the City Department of Human Resources to determine if they meet the criteria to be eligible for appointment as the chief medical officer. So that's where we are in the process.
Okay, thank you. Yes, I think it would be good to continue to be updated at each of our JCCs in terms of the hiring of these key personnel.
Absolutely, yes. We will make sure we do that.
Thank you.
All right,
All right, we can move on.
thank you. Item 6 is the, and thank you very much, Priya. Item 6
Thanks,
is the regulatory affairs report.
Good afternoon, Commissioners. Can you hear me okay?
Yes.
Thank you, Mark. Okay, I'm here to present to you the Regulatory Affairs Report for the month of August. During the month of August 2023, Laguna Honda submitted 27 facility reported incidences to CDPH. During that time, we did not hear of any anonymous complaints from CDPH. Of those 27 cases, 19 were allegations of abuse, with 7 being resident-to-resident interactions. There were 4 misappropriation of resident property and 4 adverse events. During the month of August, as you know, we also supported a fire life safety survey. We had 2 surveyors here on site. They arrived on August 8th and concluded their survey on August 11th. The facility submitted an approved plan of correction on August 16th and was formally approved on August 18th. Outside of that survey activity, we did not receive any other document requests or survey visits. We still continue to have over 260 open cases with CDPH at this time. And then you have on the second and third page the breakdown of facility reported incidences as well as the outcomes. Happy to answer any questions.
Thank you, Naz. Is there public comment?
Yes, folks, we are on item 6, the regulatory affairs report. Please press *3 if you'd like to make comment. I see one hand. Mr. Minetshaw, you're unmuted.
Thank you, Mr. Morowitz. On this regulatory affairs report, it's troubling again seeing 27 FRIs in a single month, particularly the 2 unknown sources of injuries and the 4 adverse events that are reported to CDPH. I'm wondering why, with maintaining staff at the staffing levels back before decertification, why you are continuing having so many injuries of unknown sources and other adverse events. Thank you.
That is the only public comment for that item.
Thank you. Any comments or questions from the commissioners? No? Oh, Commissioner Chow.
Thank you. I am still quite curious. I thought that at one time CDBH was moving quickly on these fries, and it does seem to have slowed down, and we're back to over a year and a half now of these. So I thought at one time, now as you mentioned that looks like they were making a concerted effort to really catch up, but lately they seem to be doing anonymous complaints one at a time. So is that that they're going to come back and look at these 2-year-old issues, or are they just going to start again with the new recertification and say, well, we'll begin at this point? Or are we going to have to go through all of these, which are now nearly, some of them are over a year and a half old?
Yes. So my understanding of the intent was that they were going to come back and continue their review so that they can close out these cases. But that has not occurred. I'm not sure why. I have also reached out to the district office to make sure that our list is accurate so that we can reconcile, as we've talked about before as well. And I have not heard an update there either. And they continue to prioritize anonymous complaints for whatever reason that might be.
Okay, no, thank you.
Of course.
No additional questions or comments. We can move on.
All right,
Thank you,
thank you.
Naz.
Thanks, Naz. Item 7 is Laguna Honda Hospital policies.
Good evening, Commissioners. Today I have 38 policy and procedures to present. 22 of them are hospital-wide. 4 of them is from the previous JCC and is being represented. The first one is 20-02, out on pass, 20-14, leave of absence and bed hold, 22-07, A01, restraint-free environment, and 23-01, resident care plan, resident care team, and resident care conference. There are 2 new hospital-wide policies. The first one is 22-19, Family Council, and the second one is Patient Classification System, PCS, and staffing requirements. There are 17 revisions. There is 22-03, Resident Rights, and also the appendix. We renamed the policy and added residents throughout the policy. The next one is 23-03, Screening and Response to Suicidal Ideation, updated to current practice. 70-01, C2, Spill Response Plan, also updated to current practice. 70-01, C5, Emergency Responder Antibiotic Dispensing Plan, also updated to current practice. 70-01, C7, Power Outage Response Plan, also updated to current practice. 70-01, C10, Code Silver Active Shooter, also updated to current practice. 73-01, Injury and Illness Prevention Program, updated to current practice. 73-02, Asbestos and Lead Management Plan, also updated to current practice. 73-05, Workplace Violence Prevention Program, updated to current practice. 73-06, Bloodborne Pathogen Exposure, updated to current practice. 73-10, Handling and Storage of Medical Gases, also updated to current practice. 73-11, Medical Waste Management Program, updated to current practice. 73-12, Safe Resident Handling, also updated to current practice. 73-13, Employee Annual Health Examination, updated to current practice. 73-14, Personal Protective Equipment PPE Policy, updated to current practice. And the last hospital-wide one is 73-17, Hazardous Energy Control Procedure, Lockout, Tagout, also updated to current practice. There are 15 departmental policies. The first one is from EBS. It is a revision. Policy number 11, Environmental Services Policy and Procedures. There are 14 nursing policies. 12 of them are revisions. The first one is the D1 2.0, Resident Activities of Daily Living, updated to current practice. D2 3.0, the Attachment 1A, Tub, Bath, and Showers, updated to current practice. D5 4.0, Arm Sling is a minor change. D6 1.1, Battery Operated Lift Transfer, updated to current practice, and is also related to a finding. D6 2.0, Transfer Techniques, this is updated documentation location language, and also related to a finding. D6 5.0, Ambulation related, this is updated the policy attachments. D9 2.0, Bed Making, updated to include low air mattresses. D9 6.0, Water Pitchers, updated to current practice. S 1.0, Assistance with Elimination, also updated to current practice. G 4.0, Measuring Height and Weight, these are minor updates. G 5.0, Blood Glucose Monitoring, updated to current practice. And K 9.0, Management of Residents on Hemodialysis, also updated to current practice. There are 2 deletion requests. The first one is D2 2.0, Bathing Alternatives. This is requesting to retire and use the Elsevier, isn't that right? Multi-skill quick sheet instead. And then the last one is M15.0, Remove Portable Bed Alarm Skills Checklist. And that's it.
Okay, thank you, Carmen. Is there public comment?
Folks, we're on item 7, Laguna Honda Hospital Policies. If you'd like to make comment, please press *3. I see no hands. No public comment.
Okay, thank you. And I know that there were a number of responses to the questions and clarifications posed by members of the commission. Thank you for that. I think there may be some additional comments or questions at this time. Commissioner Green.
Well, thank you for all this hard work and for some of the clarifications. I haven't had time to look at this yet, so I'm just wondering how we proceed there were a few things that I just had questions about, and I don't want to take time in a public forum to go through them, but I'm wondering if perhaps we can get a final copy of some of these corrections or elaborations. Um, we can, I think, probably approve what's here, but it would be helpful before the commission at large has to do that for us to be able to see these final, and also perhaps even a different color of what was submitted to us originally in red compared to what's been changed. The only other thing, and I asked this when it came to the guide for Code Silver, these policies are necessarily elaborate, but I have to say, I even found the pocket guide for Code Silver to be very confusing and to be really very dense. And I just wonder what we're doing for these really key policies to have, honed down bullet points for what people need to know. Because, in an urgent situation, whether it's, getting a medication to a patient or otherwise having to deal with an emergency situation, it's so helpful to be able to glance at something with as few words as possible. So I'm curious to know what the strategy or philosophy is, kind of evaporating some of this down to the core things people need to know. It's overwhelming, all that's expected of the staff. And, there's a point at which it's where's Waldo? You're trying to find the critical things, and it's really difficult to do. So I'm wondering whether that's being done, how you're prioritizing the various policies for which that needs to be done, and then what processes you might be using to make sure. I know there are things on the various neighborhoods, but if they're as elaborate as that pocket guide that was included in here for Code Silver, it may need to be honed down further. So I'm just curious about that.
So
Do you have a
currently we do
answer?
have a, I'm sorry, go ahead, Naz.
It's okay.
No, go ahead. Thank you. Thanks, Naz.
Okay, no problem. So it is always a challenge to balance the several revisions and updates that come through our policies, especially this time of year, right? So as you might recall, the skilled nursing facilities are required to review all policies annually. And so often at this time of the year, for you all, you receive a lot of policies. What we then do is communicate that through our daily all staff communication in terms of policy updates that occur. Any policies that have updates that are very significant will have in-person discussion and sometimes in-person live in-services. For example, the one around the Code Silver, many of us were required to attend a training just a few weeks ago regarding the updates and expectations for this policy. So it is triaged and discussed. Policy owners are responsible to do that critical thinking and review, and of course, quality management supports as we review the policies as well. I hope that answered your question, Commissioner Green. Apologies if I missed a component of it.
Yeah, I just think it would be really interesting for policies you all consider critical for sustainability of certification to see what you've done to really clarify and make things simple and straightforward so that people can comply without all the words draped around them.
Sure, absolutely. Go ahead, Roland.
Yeah, thanks. Great reflection. And as you know, that's a challenge in every particularly large institution of which Laguna is. And typically, in addition to what Nas said, staff are always being directed to the online policy and procedure. But as you said, when you're in a hurry, that's just one more step. One of the ways that we attack this in the emergency preparedness world is to have that flip chart that says earthquake, fire, that. So I think there's an opportunity for us to do exactly what you described, take that from a recertification operations approach. Is there a flip chart that can then highlight the top 10, 20, 30, 40 policies that we think are important for staff to know? So Nas, let's take that back to QM to see if we can work on a regulatory operations version of a colored flip chart.
We can do
I
that.
think that would be terrific. And especially as you said earlier, there's turnover in the admissions policy group. So we always have turnover, and to orient, and we have registry staff as well. So to have something really readily available, I think would be so helpful. It's so complicated. Yet there are probably some things that are absolute priorities. And, you know, I'd be fascinated to know what research has been done about how people learn. Because, you know, do you give them everything and have them prioritize, or, you know, it's a whole idea of how you learn complex processes and what, you know, not only how do you learn it, but how do you recall? And I mean, it's a challenge in everything we do. I have it in my own office. It's a huge challenge, but it really helps, I think, to have that distilled information that you can refer to repetitively. And then on that skeleton, you build further knowledge. So I'd be curious really in the future to hear how you're proceeding in that.
Okay, Dr. Chow, do you have additional questions?
Yes, thank you. I was just sort of reflecting on what we're going to do with all of these. There are several which rightly pointed out some issues of either language clarity, but not dealing with the policy itself or the procedure itself, that we were not questioning that, but questioning the clarity of parts of this, or even the way that it was constructed, trying to understand if it was ambiguous. And others, we, just like in the batch that we just got for revision, was to actually then take a look at how we could make it clearer and what was closer to what we thought would be a reasonable policy. So then, like we did before, we said some of the policies really were needed for survey purposes because they need to see a process and procedure in place that we were doing, so that those are the ones that we then did pass and brought back, and which are here. There's 4 or 5 of those. And then the others, we just blocked them in and put them onto the consent calendar the last commission meeting. So the question, and staff really worked hard today to bring these responses, which were a mix, including, you know, we're going to correct the word data to date and so forth, all of which were okay. But we've not had a chance to understand the priority that you all want, what has to be passed before the Medicare survey arrives, so that it's been updated and they feel comfortable that we have actually looked at it. Others in which, again, like we had in the past, and I just use family council as an example because I found it really quite confusing, even though you all seem to have a good explanation as to what it was. That merit a little more discussion, just like we had with admission and with out on pass and so forth. So not quite sure the need that the facility has for which ones really they need to at least have the process updated, and we should then do that and pick out those few that we want to continue to talk about, or the ones that have already been corrected to the satisfaction of everybody. Those could go forward, but we don't have the time today to go through those. So, Madam Chair, what, should we try to find what we need to do in order to be in compliance, and yet at the same time, then we could, we could block the whole thing, say they're all in compliance, and then pick out some that we'd like to bring back and talk about. So, that's another way.
Right. And I know we've used both approaches.
Yeah.
And as Naz said in her lead up to this, that because on an annual basis, all the policies have to be reviewed. So we do a lot of catch up at this time of the year. And so that, combined with the complication around those policies and procedures that need to be in place for survey purposes and recertification purposes, it puts a lot of pressure, I think, particularly on the timing of things to get approved, where there is more than just a lack of clarity on some of the language or some of the process itself. So what we've done in the past is ask for approval and then set aside some of these policies to get reviewed after data has been collected and some experience with particularly new policies, so that we can revisit whether there needs to be another revision or some more clarity. So that's one approach that we had. And another is we've actually delayed a few where there has been, we've considered them, the public has considered them quite key, and need more work. And so those are the two things that we've experienced. And so we're in a little bit of, sort of, which is, per Commissioner Chow's question, how do we determine a way forward such that we can give the full commission confidence that the policies that we're asking them to approve are in fact those that really are appropriate and needed at the time, versus we're just trying to be expedient in order to get something in place.
So I'd love to hear Naz's thought, but my first thought would be that perhaps we do a little bit of both of those, do a prioritization. But more importantly, I think we need to, any questions or concerns you have, we need to make sure we get those back to you and completed prior to coming here so that you can take the appropriate action. So whatever process we use, seems like it didn't allow that to happen this time, but I'd be curious to hear from Naz what your thoughts are how to fulfill this request from the JCC.
No, before you speak, if I may say something quickly, Commissioners, the action on the table is a recommendation for the full commission to approve, just to be clear for the public. It's not you all approving today. And I also want to give credit to the staff that they did send the policies weeks ahead of time and that you all had many things to do, but I want to give credit that the process allowed a lot of time and that it's a difficult thing, I think, for the commissioners to review and get comments in, but I want to make sure that staff doesn't think that we're taking that for granted. That's all, Nas.
Thank you, Mark. I appreciate that, and I appreciate you highlighting that. It is challenging to say. I guess my ask, if the commissioners would so be inclined to approve a recommendation for it to move forward to the Health Commission, and then if there are outstanding items from what was provided, we can review and then pause those as we have done prior. In regards to prioritization, we can absolutely take a look, but the challenge now becomes, because of the time of year, that when surveyors come, they're going to ask for our annual policy review. And we will be required to demonstrate that we completed that.
So we are, I think that this is going to be an issue not just for this period and this time, but it is going to be an ongoing thing. And so we want to be careful about how we decide to proceed going forward. What we have done in the past is recommended approval for the full commission. And then we really need to work very closely with staff at Laguna Honda to make sure that those policies and procedures that are sort of that have been evidenced to be key policies and procedures for review for just ongoing patient safety and quality of care, as well as those that have had some confusion around whether it be language or their implementation. We really do need to set I think, an agenda in the future for when those are going to come back, along with an ability to prioritize or some indication of prioritization of those policies, because otherwise we're going to continue to ask the same questions about whether it's appropriate for us to approve or to recommend approval to the full commission without really having had the time to fully vet or fully understand what it is that we are approving or what we are recommending for approval.
Okay.
So I would suggest that we do what we have done in the past for now, knowing that this is not an ideal way to go about what we know is a requirement at a time of the year that, in this particular year, is made more complicated by the recertification, but also knowing that in the future, and maybe, especially with phase 3 regulations and other things that might be coming through, this may just be an ongoing complication that we're going to have to really weave into the agenda in a way that makes it more timely and brings more confidence to the process.
I agree. So I would suggest that, Nas, we perhaps work with Mark and put together a proposal of how going forward we could do this differently to address the issues you just mentioned. I think using some of the prioritization, but perhaps then looking at the total number of policies and doing more front loading earlier, or as opposed to trying to get them all within the last quarter of the year. I just think we need to look at what those options are.
Be happy to do that.
Yeah, and I want to give credit to my fellow commissioners because of the level of detail that is that they put into the effort at reviewing these. I think speaks to the commitment that we as the JCC have to make sure that we are fulfilling our responsibility and oversight and not just passing something that needs to be passed because of the requirement to do so. So overall, I think the major issue of the requirement to review is being accomplished. So that I think I have confidence in this, the question of whether we're actually doing a review with regard to the policies themselves and their appropriateness for implementation, whether they be priority policies or run-of-the-mill, is the one that I think is more the question that we really want to address.
Okay.
And so maybe Naz can answer. How many more policies are there for this cycle?
Carmen, I think we've wrapped it up at this point for this cycle.
And we're
Okay,
starting.
then we'll start again.
We did a big push to get a lot through for this JCC,
Yeah.
so in preparation for a survey as well. But Carmen, please correct me if I'm wrong.
No, thank you. So I wonder then, since it's one more batch to go, if we could do the same sort of like we did last time, those things that had no comments. So it'd be like this, we could recommend this block. Those that had no comment are clear to go forward. Those that there were comments, those of us can look at it and say they're substantive or they're not. And that there might be a group that we want to have come back, like 3 or 4, like we did this time, to clarify the discussion or something. And of course, that's work for Mark and Naz to forward out. But like last time, you all came up with the 3 tiers, and we got through the non-controversial ones right away. Others we might approve, but then say that we'd like to have that come back and then have further discussion to improve on. And there could be one block that really we had to figure out, which probably isn't, from what I can see. It probably might be that I know Commissioner Green is concerned about, the silver bullet thing, or whatever we call the.
Code silver.
But in any case, the simpler it sounds like, the better, rather than having 2 different rules that one follows, saying that one's incorporated into the second one, and you can't remember the first one as well as the second one. When the 3 rules were just, secure yourself and leave if you can, or and don't fight unless you really have to, right? I mean, see, I remembered at least 3, but we could discuss my family console issue too, but and that might be one that says, well, the protocol is fine. We just need to really clarify and get something, that also is more easily understood. And perhaps everybody else understands it, but I mean, that would be a discussion where, I got confused between the family groups, family consoles, and who was doing what. But from a process, there's probably not a problem. So that would be like these others, like out of pass, we pass and then bring it back for further, improvement in the document. So I guess if we wanted to, we could then, and I just throw that as a recommendation. We don't have to second it or anything. We don't like it, which is to move this block to the commission for recommendation for approval, except for and pending the fact that reading the responses that were given back to the questions, that we feel that there may be some that need further work. And if it needs further work but looks okay for proceeding with the process, we could then list that as a group. And if we really don't want it to go through right now and have a further discussion, then we could list that as a third group.
Thank you.
Yes.
Commissioner, let me check with Commissioner Green and see what.
Yeah, I would agree. I think there's some things you answered here that we don't have the final verbiage on. For example, there was a question about PPE, and it says here that Appendix A was removed, and there's a list of PPE included at 3F, but I looked here and there isn't a 3F here now, so that must be something new, and it's not on the response yet. So that's the kind of thing I mean, I'm sure it's fine, but that's the kind of thing I'd just like to see how it ended up, because that's just, I mean, I can't. And I apologize for not getting my comments back to you sooner. You know, that's just one example. Some of these things are just point of curiosity, like really tying bags, please. But, you know, I think the core of most of this, I mean, I would say we absolutely, you know, the unclear sentences because of noun and verb done. You know, some of these things are more like I think I have something about the bird team, and then there's no mention of it later. Well, that's something we can deal with. But I think, you know, just seeing what has been written, making sure that responses are clear, and I have no problem certainly approving the simple stuff. And I think there, at the end of the day, once we read the final versions, there'd be very little extraction.
Let me see if our secretary has some suggestions about how to proceed.
So I'd like to summarize and possibly move us forward. Based on what you all are talking about, it seems like today you will can recommend for approval the whole block. I will get from Carmen and Naz the revised policies. So you won't just have responses, but you'll have the batch of that. You can compare it with the responses. And you will have that in time, hopefully on the sooner side, so you'll have in time to review. At the meeting on Tuesday, I don't have the date in front of me, but I think it's the 19th. Everything will be listed on the consent calendar ahead of time. Naz will help and Carmen will help prioritize which are priority policies. And you all can extract any of those policies from the consent calendar to discuss that day and get some answers. And anything that you're not satisfied with, we can table to the next meeting. So I think we have a process for today to move forward.
Yeah, thank you for that summary. And I think that at this point in time, that's going to have to suffice. But really need to mark that there is some work that needs to be done. And again, it's not questioning staff's competency, excuse me, in doing this, but it really is the nature of the requirement on an ongoing basis, and then the timing in this particular year of the other things that have made it difficult, I think. One, because of the phase 3, and then also because of the recertification. So the prioritization piece, I think, is related to that, but that might be something we want to do ongoingly anyway, right? And then being able to mark the ones that we really want to have come back on the agenda for review after some data has been captured and some experience with the change policy has happened. So if we can make sure that those things are in place, then I think we can feel confident with the caveats that Mr. Morwitz summarized based on the recommendations from the committee to go ahead and ask for a motion to recommend approval to the full commission. Anybody want to make that motion?
Yeah, I would go ahead and recommend that we recommend to the commission the approval for the policies and procedures with the caveat that upon reading the explanations that were provided by staff, which much appreciated, may require then that that consent be withheld and as a pending item.
Second.
Okay, all those in favor? Aye.
Aye.
Aye. Okay,
Thank you, everyone.
thank you
especially
very much.
Naz and Carmen
that.
for your patience. Item 8 is a consideration for a closed session.
Your motion?
Second.
Okay, all
And
those in
then,
favor?
Can I see if
Oh,
there's
yeah, sorry.
anyone would like to make public comment on this item? We're on item 8, the consideration for closed session. All right, I see no hands, commissioners.
Okay, all those in favor?
Aye.
All right, please give me 30 seconds. Folks on the line, you will not see or hear us, but we will be here and we will be coming back into open session after the closed session is over, if you would like to wait for us. Thank you so much. All right, commissioners, we are back in open session. Please consider a motion to disclose or not disclose discussions held in closed session.
Move not to disclose.
All those in favor?
Aye.
Okay.
And then a consideration for adjournment.
I move for adjournment.
Second.
All those in favor?
Aye.
Thank you. Thank you all very much.